Thank you, Phyllis. Thank you for this very kind invitation. It's a pleasure being back at McGill. Had the opportunity to come to medical school here. So it was a very rich morning, and I received the text at the same time as everyone, so I'll just try to highlight key points of the presentations that I thought were all very interesting, and maybe bring some questions that could open to further discussion. So the first talk by Dr. Wazana showed a very, I think, innovative and integrative way to look at developmental psychopathology in terms of considering vulnerability factors among infants, even antenatally, at the interface of parental sensitivity. And this dual way to think has much promise for us in terms of allowing us to screen for at-risk families and to design interventions that can really influence outcome. So Ashley spoke about prevention, and he spoke about the importance of screening for depression antenatally, since the continuity is very clear between prenatal and postnatal events. If we intervene early during pregnancy, we really do have an impact on the developing infant. Postnatally, the emphasis was put on maternal sensitivity, and that includes also paternal sensitivity, and also the various infant risk factors, what's called temperament. When I trained at Brown, we a while back, there was a lot of emphasis on attachment issues. Temperament was paid some attention, but now more and more research is showing that there are some early infant characteristics, early infant neurosensory characteristics that we can train to screen better, that will have a circular or a transactional impact on how infants develop, and it's very important to screen for that. So I had several questions around that and comments around that very good talk. And one was brought up in during the question period. It's basically, what do we tell parents now, especially middle class parents who look at blogs and who look at in the media about the effect of stress, and now they're stressed about being stressed. So it's a real paradox that we run into. And this fundamental research on epigenetics is very important, very promising, but the way that it's relayed in the media and by us as clinicians is something that we need to be very aware of at a developmental period among parents where they're greatly sensitive to feeling sense of guilt and a sense of shame, because after all, it's a time in your life that you want to be at your peak. And the first people to be aware of the potential negative effects of stress often are the parents. So what do we tell them? Well, from my clinical experience, what we tell them is that it's important to accompany parents. And we don't want to end up medicalizing. It's a critical issue. We don't want to end up medicalizing stress and anxiety and dysphoria during pregnancy, because after all, it's a hallmark of transformation. It's a hallmark of change. So we need to work together in larger systems to make sure that we provide a coherent accompaniment with families. It's much less high-tech than doing epigenetic DNA analysis. But on some level, it really is a critical component how we speak to each other in terms of how we create a sense of continuity within obstetrical care, which is, as you all know, very focused on risk. So it tends paradoxically to lessen women's sense and parents' sense of security. So we want to address these communication aspects. And we want also to bridge what goes on antenatally with postnatally, because the teams, as we all know, tend to be split and tend to be separated. And it's very critical at this high-tech era in every subspecialty that we have to bridge the gap between communication across teams, or else parents end up feeling very stressed out. It's a very it's a very circumstantial way to tell you that at times the system drives parents crazy. And that the screening that we need to do has to be patient-focused, but also that it's very critical for us to think in terms of broader systems and how we provide continuing messages that can be carried through in the various segments of care that parents experience. Actually, the obstetricians have a lot to teach us about that. They've put together are there obstetricians or perinatal doctors in the audience? Mm-hmm. Well, the obstetricians certainly have a lot to teach us with that. They've put together is the program More OB, or in French it's called AMPRO. What it is, it's a program of interdisciplinary communication which allows teams to zoom onto their areas of communication. And what was found is that if this happens, there's a lesser degree of unnecessary cesarean sections, and the rate of people being sued goes down. So if you help really with that framework that has been built, if you help families have a greater sense of security, then you end up doing a lot of preventive intervention. So systemic issues are very important. One provocative question that I would ask this morning would be: is perinatal depression a psychiatric disorder or not? The rates are very high. You end up with postnatal rates that have sometimes that are as high as 30% in some studies. Fathers have been found in meta-analysis to have 10% rates of antenatal depression. What's going on here? If everybody has it. So I think one element that we tend to forget is that perinatal depression, it's a heterogeneous condition. It's heterogeneous with lots of different risk factors and lots of different symptom clusters that may not have all the same meaning, and that certainly should not be addressed only at an individual level with psychotherapy, family therapy, pills, and all. I'm not saying that these things are not good. Obviously, they're critical components of it. But again, it's this notion that broader system issues need to be looked at. Also, at times, when you look at the literature on perinatal depression, there is a lack of consideration of other comorbidities that play much of a role in infant outcomes and in the evolution. For example, attachment-related issues, representations of the infants, comorbid personality disorders. When you look at the literature on perinatal depression, it's always important to ask whether these aspects have been looked at. And some of the talks this morning also underlie the importance of looking at personality factors. So when you look at, so let's focus now on the postnatal aspects. The early signs of psychopathology among infants are often very subtle. It's a paradox because they're harder to see at times, and they have long-standing effects on the infant. Early cognitive, language, neurosensory. We need to train for that, doing that. And the split actually is that some people do mostly antenatal, some people do child psychiatric and work with children. And there needs to be some better communication in terms of recognizing early infant problems, because sometimes this will be recognized in the pediatrician's office. It could be recognized at postnatal follow-up. And it's not just to screen mothers for various conditions, it's to look at particular factors that relate to infants. So ante and postnatal are really a continuum. The infant doesn't have, obviously, the same judiciary status antenatally and postnatally. But these elements are on a continuity. Now moving on to Dr. Hayton's talk, it's a discovery. We've been neighbors for a long time, and I'm very privileged that finally I'm getting to hear the fruits of your very long-standing commitment to this population, and I was awed by the expertise that you demonstrate and by the rigor and warmth that you used speaking about families. So you spoke about the mother-infant interactions in depression, and you spoke about the semiology of mothers. And again, I want to emphasize that the semiology is very heterogeneous. The signs are very different. When we were at Brown, we looked, for example, a mother who's mostly withdrawn and self-depreciating is very different for her infant than a mother who's very irritable. And another one, maybe that you might have not had the time to emphasize, who's very guilty and who also will be at times overstimulating her infant because she's the first one to know that she doesn't have all the stamina that she gets. So you end up in these situations with an infant at 6 o'clock at night who's at the worst time of its day, and with a mother with an endogenous depression who suddenly has a spurt of energy. And what do you get, you think? You get all these missed interactions that can have negative effects. So you emphasize the semiology for the mothers, the semiology also of the infants, and the important question of the vulnerable time of exposure and the length of exposure. Cortical blindness, we know that there are moments in life where if you get not exposed to some key stimuli, we have long-standing scars, and it's probably the same with infants. And when we say that, we don't want to make parents feel guilty, but we want to use that to really intervene when it's the right time. So you also spoke about the role of attachment, and I was glad to hear you review the McMahon study, who wrote about the protective factors of attachment in postpartum depression. We could have also a long discussion about issues of measurement of attachment in adults. You use the Bartholomew questionnaire and how this validates with various other narrative forms of attachment measures, but maybe that's for another time. And I'm sure that your team has had these debates in terms of feasibility and all. But just to emphasize that attachment in adults, it's not just something that you answer on a questionnaire. It's a process of discourse that you use. So it's always very challenging when we look at the literature and we try to accomplish these things in our clinical milieu, how you can do about measuring this, because you want to have valid measures, but at the same time you need to think in terms of feasibility. Dr. Hayton emphasized also that the improvement of maternal depression is not necessarily accompanied by improved infant outcome. That's such an important point, especially for our adult psychiatric colleagues who treat perinatal depression as a quote-unquote a woman's psychiatry issue, working under a bubble, working with the TCC and pills, and then the symptoms of depression lift off. But if you have not addressed the interactional aspects, if you have not looked at the infant developmental issues, then the preventive role that you might want to play may not pan out because some other interactional aspects have not been addressed. It's not quantum mechanics to work with infants and fathers in your office. And at times we can use this old therapeutic technique with the empty chair also, that the infant can be sit in our office in this empty chair even when we meet with the mother individually or when we meet with the father. But let's remember that if we want to have a real preventive impact on infants, we need on some level to work on parent-infant interactions. Dr. Hayton emphasized also the dyadic types of interaction. I just want to emphasize here that there is more and more research and more clinical work that looks at early triadic interactions. When I trained a while back, we thought that fathers came in when the baby was at the Oedipal period, right? It was suddenly when you're king of the month, and you're being discovered. Very well designed research, especially done by Elisabeth Fiva de Persinge, who is in Lausanne, and now with John McHale also. They've shown that early triadic interactions take place, and more are descriptions of the semiology of perinatal depression must include interactions with fathers. This is all the more important also because, as I was alluding to, fathers have been shown to have 10%, as high as 10% rate of perinatal depression. And earlier this week, just yesterday, with one of the heads at St. Justine, I was having this discussion. What do we do now? We're a mother-child hospital, but 10% of the guys have depression. Do we open charts for them? What are the medical, legal, the clinical, this and that? What we need to work with that. And more fathers are very involved. And when you call them in, they come. You call them on the phone when you're with the dyad, and they answer. They answer. It's just a matter of really making a statement about their importance. Finally, Dr. Hayton emphasized the role, spoke about some comorbidity, and there's this notion right now of comorbid anxiety having a significant impact independently or semi-independently from depression. So if you have pregnancy-specific anxiety, I think as one of the articles that Dr. Wazana distributed, that may have an impact on the development of the infant, and more importantly, for the obstetrical colleagues, this can also have an impact on birth issues, intrauterine growth retardation, preterm labor, preeclampsia, outcome of gestational diabetes. So we need, as mental health professionals, to use that language if we want eventually to have meetings where we get more obstetricians and pediatricians joining us in this sort of thinking. Now, Dr. Paris's talk. I was very impressed and touched that an international leader in personality disorders spends such empathic and extended thinking about parenting. Personality disorder patients, as we all know, they're a handful. And all too often in clinical settings, parenting doesn't have the place that it should have because there are so many issues that we need to deal with. For example, there are programs where you deal with personality disorder patients, DBT and all, and I'm always wondering, why isn't there a parenting module that should be all the time included with these treatment programs, both for preventive aspects, and second, because as Dr. Paris emphasized, parenting is a very stabilizing, on some level, aspect and can provide major reparative opportunities for parents who are very vulnerable. So I think there's really a good direction there, and I hope, Dr. Paris, that you have an opportunity to present that talk to groups of people specialized with borderline personality disorders. You describe the sense of isolation and stress that mothering entails, and the importance of connecting and of social support. And when we talk about social support, I think for parents with personality disorders, there are two components to this. One is the presence of a social support, and the second one is the use of the social support. It's like what Winnicott said in '69, and the use of the object, not in terms of being manipulative, but how do you use the object? How do you use the other? And how do you feel about asking for help? When we become parents, It's destabilizing for our identity. There are lots of things that are happening in our identity, and we need to lean onto each other for that. There's an interdependence. If you have an insecure attachment history or a disorganized attachment history, then it becomes very difficult. So at times it's not just naming, hey, see this person, that person, that person. It's how do you feel? What's the impact? What's the emotional impact suddenly of being in need of somebody? And then it triggers very powerful reactions. But at the same time, it can be very reparative if you bring it out in the session with your parents. So parenthood is an opportunity for change, and you emphasize that. And I think that depressive symptoms are often a hallmark of an attempt to change. So depressive symptoms and anxiety symptoms are not necessarily part of a psychopathology. If you constantly frame these symptoms as part of some psychiatric condition that parents have, then on some level, you risk of depriving them of a way to look at this attempt at transitioning, at transforming the self, and leading them to another level of equilibrium. I'm not saying that we should not screen for depression or that we should not give antidepressants. We do research on this at St-André. I mean, it's a very important element. But very often depressive symptoms are a hallmark of change. And let's remember that when we work with families. Two more comments maybe, and then I'll stop. One aspect that could have been emphasized also in the interactions with borderline personality disorder is the question of disorganized attachment. Every perinatal clinician should get familiar with the semiology of disorganized attachment. 2 days ago with Dr. Schwartz at St. Justine, we were seeing a young boy who came to his mom for reassurance, and suddenly what this little guy did was that he put his hands around her neck. That's disorganized attachment. Longitudinally, this leads to child psychopathology. And we're often in a perinatal setting in a very good position to see that and try to work with that. Of course, borderline personality has good rates of recovery. You've made us aware of that. But let's remember also, as Michel Lemay often says at St-Justine, Michel Lemay was a senior child psychiatrist at St-Justine, that the time of the child is not the same as the time of the parent. Often you can have parents who come a long way over 2, 3, 4 years to become sober, to stabilize their interpersonal relationship. And as adult therapists, we use parenthood as a stimulant for them to move on. You want to get back your child. Well, very often it's too long for the infant. And experience shows us that if you disrupt attachments early on of children who needed to be taken away from borderline parents with a high level of dysfunctioning, and if you bring them back, then you create more pathology across generations. So it's a very painful type of decisions that at times we need to think of. But it's important to support change in borderline mothers, but at the same time, at times we need to have the guts and the honesty to say it's too late for you to regain custody of this child and to really take a stand for that, unless we want to breed more psychopathology across the ages. So I'll stop here. I'm sorry if I've been a little too long.